out, and then it increases their range of motion. And in some cases, it's so far gone, right? It's the entire cartilaginous complex. So now you've got bone rubbing on bone, right? And this cartilage does not rejuvenate as other cartilages do in the body. And so you just have to clean it out and then fuse it up, as in the case that we saw yesterday. Okay. Now, in cases where there is a combination of a patient may have a bunion on one toe and other maladies on the other toe, they can all coexist at the same time, just based on what the patients are having. And if you find patients with diabetes, you'll find that they have multiple issues going on with their feet all at the same time. Okay. So Hallux valgus or metatarsus primus virus, right? Normally when you see these, there is a bunion, right? You have medial deviation, right? Medial deviation of the first metatarsal, right? Medial deviation. Why is it medial, regardless of which foot? It's medial because it's deviated, lateral deviation is deviated away from the midline, right? Regardless of which foot it's on, it's deviated away from the midline. You have medial deviation of the great toe, right? So the metatarsal points towards the outside, the great toe points towards the inside. It essentially just pushes it. If you picture how your shoe, right? If you have a narrow toe box shoe, it's wide right before it gets to the toes, right? And then it gets pointy at the toes. That's exactly the shape that the foot takes. Okay. More common in females at a ratio of 10 to 1. But there are men that wear narrow toe box shoes as well, right? And when those happens, then when they do, then you have this condition occurring. You've got pain, you've got swelling, the patient presents. Pain usually lessens when they take their shoes off, right? But because of that angulation of the great toe and the metatarsal, then you may have callus formation building where it actually rubs against the toe. In most cases, you see a patient with a bunion, there's a corresponding callus, or at least some irritation. And if it progresses for too long, then you've got some loss of sensation because it irritates the frontal nerve at that rate. Range of motion is sometimes significantly limited, not always though, because in very new cases, or cases that are not extensive, they may have full range of motion of the great toe, right? But in a lot of cases, by the time they come to see you, then the patient already has quite a bit of problems, right? Normally they don't come to see you when the issue just started. So we talked about the calluses, we talked about the bunions, bunionettes. Just make sure you assess for mobility of the toe. When we get into issues with the lesser toe, you'll understand why assessing for mobility at the MTPs or the interphalangeal joints is absolutely necessary. Now, unless it's contraindicated, right, and we talked about this yesterday, you always get what kind of x-ray for the foot? Weight bearing. Okay? Somebody, I'm going to change an answer on the test. I bet you somebody's going to get this wrong. Always get weight bearing foot films of the foot. Okay? This is a great slide to know when we talk about the Hallux valgus angle. Rest easy. I will not test you on angles. This is not a math class. Right? Some of you are breathing a great sigh of relief. But understand that when you see these on X-ray, understand the necessary, the means for the angulation of what that actually calls for, right? If it doesn't look straight and it's not aligned, then there's a problem. Treatment for Hallux valgus is the same as we do for much of the other issues with the foot. Okay? Number one, stop the offending activity, rest it, ice it, give them some NSAIDs, right? Good patient education. And if you do nothing else, give them what? An ugly shoe. Exactly. I know. Some of you don't like that ugly shoe, but it will save your feet. Okay. Right. That roomy toe box just allows for more room and prevents the offending activity. Okay. In most cases, when you have issues with the metatarsals or the toes, avoid shoes with heels. There are some roomy toe box shoes that come in high heels, right? Or in elevated heels. I know. See you making faces, but it's probably the ugliest shoe. But it works, right? But in these cases, you have to prevent, don't give them shoes with high heels. Because what you're doing now, you're transferring the weight of the feet while they're walking on the very thing that you're trying to correct. When do you refer to for specialty care? One indication. Yes. What else? When non-operative management fails, right? So you've done all you can. Now it's time for you to allow somebody else to help, right? And don't keep trying the same thing over and over again if you're not getting adequate results. So when there's failure of non-operative management, I've been going for surgical care or for surgical assessment. Questions about this? Morton's neuroma, right? So this is not a true neuroma. This is really an irritation of the fibrous layer of the nerve, of the interdigital nerve. A true neuroma, right, is a nerve tumor. So you've got all these internal nerve fibers that are growing out of control like any other tumor, right? This is not that. What you have here is an irritation of that fibrous layer, and then it just causes some fibrosis, begins to swell. It is within the third web space, right? And so as you walk, the patient is having these symptoms. Key thing to remember about the Morton's neuroma is that it is called a neuroma, not sure who named it, but it is not a true neuroma. Okay. Females usually at a ratio of 5:1, that's the demographics, but we have seen these in males as well, of course. And so, not because it's more prevalent in females means that you can't have a high index of suspicion if that person is a male. Okay? Patients will present with some issues with their feet. Most of them will present with complaints that there is always something in their feet when they're trying to walk, things that they're walking on marbles. It's very classic. It's almost like Achilles tendon where the presentation is, hey, someone smacked me at the back of the leg. In the case of patients with a Morton's neuroma, that's their presentation, right? Feel like there is something inside the shoe. No matter what they do, they can't get rid of it. Pain is almost always present with weight bearing. In some cases, once you get off your feet, the pain subsides, but more than often, it is present with weight bearing. So, as part of the physical exam, and skip ahead here a little bit, we like to perform the squeeze test. And all you're doing is compressing the forefoot medially and laterally, right? And as you compress it, metatarsals squeeze together, irritates the Morton's neuroma, and reproduces the patient pain. Very simple test. Squeeze test for Morton's neuroma. Sometimes patients their symptoms may be aggravated based on the type of shoes that they wear. So if they're wearing shoes with a wider toe box, the symptoms may lessen, but not always, right? But it's certainly aggravated when they wear shoes with a narrow toe box. And you understand why? Because it's almost replicating the squeeze test. Any questions about that? You always want to assess the feet for other conditions, right? And no matter what the patient presents with feet problems, right? Don't look, and you see how yesterday we all focused in on that Achilles tendon rupture, right? When in fact the patient could have a calf strain, right? So, widen your differential. It's called a differential for a reason, because there may be more than one thing causing it. Very true of the feet, because whenever there is one problem with the foot, there usually is a secondary problem, right? So always assess for that. And then you do your neuro test. Make sure they've got good motor and sensory. Questions? Is that simple enough? Okay. So how do we treat these? Just like we treat most of the other foot maladies, right? Rest it, stop the offending activity, give them some NSAIDs, have them not do the things that they do that reproduces the pain, and again, a low yield white shoebox. Dreaded ugly shoe, right? In some cases, if you use a metatarsal pad, right, and we talk about that when we get to some of the other conditions, use a metatarsal pad, you have to be careful of where you place it because you can actually reproduce the pain, right? When we get into metatarsalgia and sesamoiditis, that is absolutely paramount that you do not reproduce the condition that you're trying to solve. Right? Sometimes we can do steroid injections into the neuroma, right? And that can be actually diagnostic and therapeutic. It reproduces the pain, relieves the pain, and then it tells you that you were right, you did have a Morton's, and then the patient is happy, and you're their hero. In instances where non-operative management fails, then of course what you do, refer them for specialty care. Very simple. Questions, comments? Okay. We do understand that the metatarsals, because of their anatomic location, they actually bear some of the weight, especially during the push-off phase of walking, right? Did I lose anybody? Therefore, when you're stepping off, right, as you step off, the metatarsals are bearing the brunt of your body weight. Does that make sense? Therefore, it is highly likely that if they get irritated, then your pain is reproduced during that step-off phase. Make sense? Okay. In some cases, it can be so bad that it just with normal standing, because it does take, bear about, depending on where you are in your stance phase, 20 to 30% of your body weight. We talk about that when we get to the Achilles tendon and plantar fasciitis. Okay. Again, here's a picture of where the phalanges are, where the metatarsals are, and where the tarsals are. And behind that, so all of this is part of the forefoot and the midfoot. Behind that, you've got the calcaneus, the navicular, and the talus. It's all comprised of the hindfoot. So, forefoot pain, right, under the lesser metatarsals. So we talked about things going on with the hallux, right, which is the great toe. We're going to shift focus to 2, 3, 4, and 5. Okay? Metatarsalgia usually occurs at the metatarsal heads of the lesser metatarsals. And if you have any of the other toe maladies, right, hammer toe, claw toe, then that just makes your problem worse. Again, if you have repeated action and repeated contact with your shoe or the ground at a particular location in your foot, then you're going to have some callus formation. So how do these patients present? Right. They present with pain either with weight bearing or with walking, feel like they're walking on pebbles, on physical exam, right? They may or may not have decreased range of motion at the MTPs or the IPJs, right? But you can almost always reproduce the metatarsal head pain by direct compression. That's a way that you can tell, right? So, patient presents with symptoms of foot pain. Tell you that they feel like there is something in their shoe as they walk. Have the patient take the shoes off, you look, you see nothing, there is no swelling, there is no ecchymosis. The patient is very convinced that they've got pain and there is something in their feet, they just cannot tell. Okay. Do a physical exam, full range of motion of the toes. Then you get into the special test. Okay. What are two special tests that you can do to help narrow your differential? So you do the squeeze test and it's negative. Anybody have a problem? The answer is there. You know, when they say it, they're gonna be like, right? If you do the squeeze test and it's negative, right? You might say don't lock yourself into any one differential, right? So let me back up for a second. What conditions, based on what we've talked about so far, could the patient have? They could have a neuroma, or they could have this, right? Okay. So a squeeze test is negative, so it's not a neuroma. Then what can you do? Palpate what? Palpate the metatarsal. You're thinking too hard, right? Promise you we're not trying to trick you with orthopedics, right? And as part of your exam, remember when we did the lab downstairs, right? We talked about visualizing the bones underneath the skin and trying to find each of those landmarks, right? And so if that's part of your differential, then you find the metatarsal heads as part of your physical exam, and you directly palpate the metatarsal heads one at a time, right? Something you have to memorize, but I want you guys to kind of think through the process, just like you would if you were thinking through the process for a patient. Okay. And so, if you palpate the metatarsal heads and they have pain in any one location, right? You can tell yourself, yes, the patient has what looks like metatarsalgia, right? They may or may not have callus formation at the level of the MTPJ, right? So not all of them show up with a thickened callus on the bottom. But if it's prolonged and it's chronic, then you have this callus formation, right? So if you see that, then that's a good sign, right? That's what it is. When we get into corns and calluses, you see how this throws a little extra monkey wrench in it, because this is not a callus, but it's a corn, and they're tender in that area. Now what, right? So we'll talk about that when we begin another lecture. So you want to get weight-bearing films of the foot because that allows you to assess if there is something else going on, right? When we get into fractures, you'll see how patients that present with foot pain and stress fractures, based on where the stress fractures are and referred pain, how it can make this confusing. That's why you cannot lock yourself into any one diagnosis. Right? You just have to do the exam and just follow the protocol. Okay. In cases where this is significantly chronic, then there's a lot of outgrowths, right? We talk about irritation at the joints. We talk about heterotopic bone formation, right? We talk about osteophytes, as in osteoarthritis. And so all of those come into play when you do your imaging and part of your physical exam. So your history and physical patient's mechanism of injury should be about 60 to 70% of your, to help formulate a diagnosis, right? And then you do your, radiologic studies or your labs to help you cement that diagnosis. Not depend on labs and x-rays to treat the patients. Okay? And you've heard I'm sure some of the other instructors have told you, you don't treat your labs, you don't treat your x-rays, right? You treat the patients. But sometimes the labs and x-rays can be a little misleading. Okay, again, weight-bearing films of the foot. Treatment is still the same, right? Stop the offending activity, give them some rest, some NSAIDs. In some cases, a roomy toe box or some other orthotic device, right? If you're going to use some of these gel pads, in some cases, they actually cause more pain for the patient if you have the wrong ones. Okay? It needs to be compressible. But now you're adding something else into the shoe. So if they have this, and then they've got a hallux valgus, then you might be increasing or decreasing the maneuverable space in the foot. So be careful with that. These pads are actually helpful. You can shave these out of moleskin, right? And you can have some in your set skits and outfits or in your clinic that come pre-cut, right? When you place these, you want to make sure the metatarsal head sits inside of that central space, that central hole. All right. When non-operative management fails, then you refer them for surgical management. What do? We can do a metatarsal head realignment, right? You can actually trim this. You can do wedge osteotomies. Worst cases, you just take the thing out altogether and fuse the bones together. Lots of things that can be done. But because the patient has this and it is chronic, it's not the end of their lives. Lots of things that ortho can do. We talk about the plantar plate when we speak plantar fasciitis. But just understand that the plantar plate is at the level of the metatarsals, and sometimes it just causes more issues. All right, here we are, plantar fasciitis. Any questions on metatarsal? I was told by Colonel Heater that she exhausted every ounce of brainstem you guys had a few minutes ago, so it should be nice. Okay, plantar fasciitis. Classic presentation. Patient presents with complaints of pain at the level of the plantar fascia underneath the foot. Pains worse in the morning. They have to actually kind of wiggle their toes and move around a little bit, and then the pain gets better. During the day, if they're on their feet, it gets unbearably worse towards the evening until they go to bed, and it's just a cycle. Okay? That type of presentation or description is very classic for plantar fascia. Now, let's talk a little bit of anatomy. The plantar fascia originates, right? It originates on the medial tubercle of the calcaneus. Medial, not on the lateral side. You saw a picture yesterday where it seemed like the plantar fascia actually ended somewhere midfoot. It does not. It extends all the way to the metatarsal heads and into the proximal phalanx. That's important because all of that helps with the plantar fascia to do what it's supposed to do, which is help reduce flattening of your foot and help with propulsion, right? Help you to step off. Okay? Get to that in a second. Okay. Besides the fact that it provides support for the foot, right, and helps maintain that medial longitudinal arch. You guys remember that from anatomy? No? I only see one person shaking their head. The only one that remembers. Okay? It helps maintain that medial longitudinal arch, which is absolutely essential for not just walking, but also for preventing additional problems with your feet. Okay? Now, when all of this gets degenerated, then you've got tendinosis, it gets irritated. Patients may or may not have bone spurs. So if you picture where it's attached, and there's micro trauma every time this thing gets irritated, right? The body responds by depositing bone at its attachment on the heel, on the calcaneus. And then as this goes on for some time, now you have bone spurs, right? You can't see a bone spur unless you get an x-ray, right? And sometimes I tell you get weight bearing films of the foot, you may not see your bone spur on an AP of the foot. You'll get special juice for it. In some cases, you may have so much trauma at its attachment, in addition to the bone spurs, as it fans out. And in essence, you don't need to memorize this, but a plantar fascia is actually a broad band of tissue that fans into three sections, right? The middle section is called the aponeurosis, right? Because that's very thick and supports all the structures in the foot. And so sometimes you have a fibrous mass that develops that just compounds the patient's problems. Now, one reason why the plantar fascia or plantar fasciitis is worse in the morning is because as you sleep, your foot goes into equinus, right? What does that mean? You have to pick on somebody. What is it? If I say the foot goes in equinus, what does that mean? I'm so sorry. I need it. So it gets plantar flexed as you sleep, right? That's its relaxed position. If you do inpatient care, right, and you have patients that are lying in bed for a long period of time, you'll notice that their foot slowly drifts into equinus. Okay, so if your foot goes into equinus, what happens to your Achilles tendon? Does it lengthen or shorten? It shortens, right? So when you wake up in the morning, if you have a combination of Achilles tendonitis and plantar fasciitis, you're just in a world of hurt, right? And so most patients, we tell them, I get a tennis ball, roll your feet around, put some ice on it, have your wife or husband massage your feet, all kinds of nonsense, right? But those are all temporizing measures, because you need to find a way to help to prevent the foot from going in equinus, right? And that's where these night sprints come. We'll talk about that in a second. Okay, so we talked about the prolonged, yes?
Are you saying coitus?
Equinus.
Equinus?
You good?
Yes, sir.
All right. It's my Texas accent. So, patients that once they get up and they start moving around, it helps alleviate some of the pain, right? Because now you stretch things out, it's a little warm, but then you're standing your feet all day long, and now you're compressing this area, right? Plus, if you're walking back and forth, remember I told you that the purpose of the plantar fascia is to help maintain that medial longitudinal arch, right? Keep your foot like looking like a foot. Well, it continues to stretch and pull at its insertion, and then towards the end of the day, you're right back to where you started in the morning. It's a miserable condition to have when it's severe. So, what do you do on physical exam? Same as you do for any other physical exam. Have a patient walk, take a look at it, right? You range of motion, and then you palpate. And normally, you may have some point tenderness right at that insertion. You may or may not have heard of the windlass mechanism. Does anybody know what that is? You do? Okay. Anybody in here fishes? Or born fishing on a boat? Seen a boat with an anchor? So, if you notice how, if you watch a boat drop its anchor, right? The chain is wrapped around a big drum, and it either winds up or winds down based on if you want to raise or lower the anchor. That's the windlass mechanism. That's what happens with the plantar fascia and how it maintains stability of the medial longitudinal arch. That arch is formed by the calcaneus, the navicular, the medial, intermediate, and lateral cuneiforms, right? And remember this from yesterday? Okay. And then the first, second, and third metatarsals. Those are the bones that form the medial longitudinal arch. Okay? The way the plantar fascia helps with that is based on its attachment at the calcaneus and its insertion on the metatarsals, right? Metatarsal heads, and extension into, I told you, extend into the first phalanges, right? When you walk, there is a windlass mechanism at the level of the metatarsal heads that allows it to shorten or lengthen. You can go into the mechanics, but I promise you don't need to. I know. So it allows it to shorten or lengthen, and that's what helps maintain that longitudinal arch and allows you to push off. Right? If you get a chance and you have your own time, look on the mechanics or the biomechanics of walking, and this will make a whole lot more sense. Right? Beyond the scope of what I want to teach you today. The important thing for you to know is that the windlass mechanism helps maintain that medial longitudinal arch. So if you picture when you stand, right, the talus bears the brunt of your entire weight, especially in the push-off phase. So you got the swing phase, right? The leg that's off the ground is not bearing any weight at all. So the one that is on the ground has your entire weight. Yes? Okay. Maybe about 50% of that weight is distributed to the talus. The other 50 is spread out through the midfoot. Right? So naturally, it wants to push that arch down. Yes? And so the plantar fascia resists that by the windlass mechanism. But when you step off, just like anything else, it contracts, right? Pulls the forefoot and the hindfoot together, maintains that arch. It's kind of like if you have something like this, and you bend it, right? You push the two ends together, then it bows in the middle, right? Resists that motion from the weight of your body weight. So, if you lose that, what happens to that arch? What happens? It flattens, right? And then what? Now you've got what? Flat feet. Yes. Pes planus. We talked about that in a second. So that's how all of these things roll together. It's not just there because it irritates you when you wake up in the morning. It actually has a good function that helps you to maintain not just your balance, but your gait and stability as well, right? Significant role it also plays in proprioception, right, to keep you upright. So all you need to know about this, you can read it on your own. Come see me, we can talk and nerd out about it all day long, but not today. Okay, now, just talk about these bone spurs. So this is what you would see on your lateral film, right? You may not see that on an AP film. So if you're looking for that, although your X-ray text would take an AP and lateral anyway, and probably an oblique of the foot, but if you're looking for that, you need to look for it on X-ray, right? Now, sometimes we say we want you to try non-operative management for 6 to 8 weeks. That's a standard thing in most of our orthopedic conditions, right? 6 to 8 weeks. If you see a treatment that is outside of the 6 to 8 week window, then pay attention to that as well. But for the most part, most of what we do, 6 to 8 weeks is the sweet spot. Again, not all patients that have plantar fasciitis have bone spurs. Now you can inject into the plantar fascia at its insertion, right? That can be therapeutic in more ways than one. That injection can be painful, and your patients will never come back to see you if you do it wrong, right? But when it's done right, despite the initial pain, can be very helpful. What is one of the the downsides of steroid injections into a tendon. Weakens the tendon, right? What if it weakens the tendon to the point that it causes rupture of the tendon at its insertion? Is that a good thing or a bad thing? Depends. Depends. Because sometimes when they go to ortho or podiatry, then we just release the tendon from that insertion. The goal of you treating a patient with steroids, right, should not be to destroy the tendon. Okay? Lay that out there. Don't go and say it because Sylvester said that you should inject it so you can weaken it and have it snap. But that is one of the downfalls or the advantages of treatment. Okay? Now we've gone through and we've got all sorts of other treatments. We've got shockwave therapy. Physical therapy can just do wonders with these conditions. As a young PA, whether you are on the line or in the clinic, PT should be your friend. It will help you a lot. Started using Botox, right, to help with relaxing the structures here and relieving some of the pain as well. Another thing that I've done in my own practice, but certainly a lot of new hospitals are starting to use Botox. It takes a very long time for plantar fasciitis to go away, especially when it's severe. Now, you say 6 to 12 months, that all depends on the severity of it, right? Very acute plantar fasciitis, 6 to 8 weeks, you know, they feel better. When it's chronic and severe, especially with bone spurs, it takes a minute. Okay? But patients that have had relief over time, and years later, they still having problems, right? And again, when non-operative management fails, then send them to ortho. Another thing that we do for as part of non-operative management, and I mentioned it earlier on, is the application of a night splint. Patients are not very keen on using a night splint, especially if they're speaking with significant others, because it's uncomfortable, right? You can imagine there may be some kicking and bruising, you know, as you keep your partner. But some patients just don't like it, okay? But it does work, and this is what a night splint looks like. All that does is help to keep the foot from drifting into the planks. Questions or comments? Plantar warts. So these are hyperkeratotic lesions that can be found on the plantar surface of the foot. It can be found anywhere on the plantar surface of the foot. Right. The offending agent is indeed a variant of the HPV, the human papillomavirus. It's not the same variant or species that causes herpes simplex 1 or 2, right? And no, a patient that has plantar warts is not predisposed to having HSV1, right? It's a herpes virus, it's not a simplex virus, it's a papillomavirus. It's a big difference. You guys learned that in IB, right? Yes. Most times you see these in young athletes because someone has it, they all go to the same locker room, jump in the same shower, right? Barefooted, and lo and behold, same thing for athlete's foot, right? Very common among that population because they all do the same thing. Thankfully, we have good treatment for both. Okay. In some cases, they can be painful, and they are distinguishable from a callus because they have this mosaic pattern to them. Right? You can find them either individually, right, solitary, or you can find them in clusters. Right? How can you tell if said lesion is a plantar wart or not? When you tear it down, you'll see all these little punctate marks, right, within the lesion itself. So you can tell. If you tear down a callus, the undersurface of the callus is usually smooth, right? Smooth, sometimes white. Tear it down too much, and cut into a patient's foot, you will see tissue starts bleeding. But these, as you take the top little surfaces off, you might see these little punctate. They may or may not bleed though, but you will tell because they have that very distinct pattern. If bled for too long, you may have one lesion, you leave it around for too long, and then if you don't treat it properly, it may invade the entire surface of the foot. Worst case I've seen, a patient that he's had this thing for a long time, older gentleman, came in and the entire bottom of his foot was covered in plantar warts. Very nice guy. He was. All right, so you guys understand how to differentiate these from calluses and corns, right? And punctate lesion. Okay? And if you take a slide of it and you send it to histo, then they may come back with this mosaic pattern. Very seldom would you need to do that because you can tell what the thing is. Remember I talked about why do a test if it's not going to help with your treatment plan, right? This is one of those because you can tell it looks like a wart, smells like a wart, feels like a wart. You tear it down, it has the little punctate lesion. I mean, if you just want to learn something, you can send it to histo, but if not, well, it's not necessary. Okay? How do you treat these things? Liquid nitrogen is a way, right? And so you can freeze these off. Usually it takes more than one treatment, it takes a while. Salicylic acid is another way of doing it. Right. I've heard of just like some older remedies using bleach and occlusive tape. Some folks have used duct tape, right? Just cover the wart, supposedly it goes away. This is a practice of medicine. Don't advocate treating your patients with duct tape from the Home Depot, right? You've got other things that you can use to do that, right? Okay. Whenever there is, if these things are pretty invasive and extensive, then you might have to use some intralesional steroids, right? As you tear them down. So you inject into the area, tear it down, hit it with some liquid nitrogen, electrophoresis, and you can go. Okay. In some cases, if it gets too bad and they invade too deep into the tissue, then you will have to send them to podiatry or ortho. Mostly podiatry. Ortho doesn't like it. Just saying. All right. When you do these, if you're tearing these down or you're using liquid nitrogen on any lesion, just make sure you wear a mask so that if you have dispersion of viral particles, then it doesn't get into you. All right, take 10 minutes. Do that. Most cases, the calluses are in the bottom of the foot. They're broad. They're usually painless, but they can be very painful if they get irritated. And if there are structures underneath them, underneath the callus that's irritated, as in at the metatarsal head, then the pain that on direct compression, you might think is coming from the callus when it's indeed. So that whole condition can be painful, right? In terms of corns, they usually, not always, but usually, are on the non-weight bearing surfaces of the foot. And in cases where they are, then the one differentiating factor is that they have this central pore to it. Right? So as you tear them down, then they look like the same white tissue that you see in a callus, but it's just a small central pore. Don't recommend that you go digging into that central core trying to get the entire thing out, because that's traumatic for the patient, right? And then we talk about the plantar warts, right? With that punctate appearance to them as you pare them down. To make sense with the differences? So, if I were to wrap this up for you to make it easier to understand, weight-bearing surfaces, calluses, non-weight-bearing surfaces, corns, but understand that it can happen either way. And then the main differentiating things is that corn has a central core to it, right? A corn, right? And in terms of warts, then there's this punctate bleeding. Easy to differentiate. Okay, the posterior tibial tendon. Very, very important for maintaining that medial longitudinal arch. So it works in conjunction with the windlass mechanism and your plantar fascia in ensuring that you can walk properly. Okay? When you lose this, then potentially you have other issues happening in which you have flattening of your medial longitudinal arch or flexible flat feet. Okay? Now, patients with posterior tib dysfunction, they come in with varying symptoms that may mimic other conditions of the foot. And so you have to do a fairly decent physical exam to differentiate which one is which in the case of especially older folks. This is very common in overweight females, particularly after they pass the 50-year age mark. But it can also be found in a younger population as well. Okay. Now, what is the function of the posterior tib? Posterior tibialis, what does it do? If I contracted my posterior tibialis, what would happen to my foot? The sun plantar flexion, what else? Look at where it inserts in the picture. Inversion, exactly, right? So it's responsible for inversion, right? And some degree of plantar flexion. And so it works with the other structures of the foot for these functions, and therefore when it doesn't work, then you understand why you have flattening of the feet, right? Make sense? So, we're going to talk about this in a quick second, but which tendon has the opposite action? Primary tendon for eversion of the foot. You're absolutely right. It's the peroneus longus, right? It does the opposite of what the posterior tib does. Both of them actually aid in plantar flexion of the foot. One does more for eversion, one does more for inversion, right? And if you recall from anatomy, peroneus longus snakes under the foot and inserts on where? Where? Base of the first. Yes. Peroneus brevis, you're almost there. Peroneus brevis inserts at the base of the fifth, right? And they both help with downward flexion. The reason why you get eversion with peroneus longus is because as it contracts, right, picture your foot, it pulls the foot that way, right? Because it wraps under the foot, inserts at the base of the first, and wraps further on. Okay. Know your anatomy. You will need to know your anatomy for your exam. Okay. You will need to know your anatomy for your clinical practice. I am here for you all day, every day, if you take that test. Patients with other risk factors like diabetes, hypertension, and other connective tissue disorders, then they tend to have issues with the tibialis posterior. So these patients will present with pain, swelling, sometimes on the medial aspect of the foot, They will tell you that the ankles continue to roll. When they walk, you will see that the foot might actually go into valgus, right? Which means it will flatten out. Okay? And they may or may not be trauma. If you don't treat these things appropriately, then you end up with permanent flat feet and or osteoarthritis of the foot. Loss of the posterior tibialis is very evident in patients with Charcot syndrome, right? Charcot arthropathy. And remember, what diabetes does to the foot, right, and to tissues, weakens tissues, weakens nerves, causes dysfunction. Now you get flattening of the feet. Okay. Classic for posterior tendon dysfunction is something that we call the too many toes sign. So, in a normal foot, if you stand behind the patient, have the patient stand erect, the long axis of the leg, of the tibia, should align midline with the calcaneus. Yes? Look at any normal person, have them stand in front of you, and you should see a straight line. Generally. Right? You bisect the Achilles tendon, should go right through the calcaneus. In a patient with posterior tib dysfunction, right, you will see upwards of 3 or 4 of the lesser toes on the lateral side, right? Versus a normal foot where you may or may not even see the small toe or the fifth metatarsal. Okay. So, to understand what the too many toes sign is, right? And it's just you have too many toes on the outside of the foot when you look at the foot from behind. Whoever named this right on point. Okay. And so the foot is in adduction, which means it's pointed outwards a little bit, and the heel is in valgus. We talked about valgus and varus at the very beginning of the class yesterday, right? Understand what that means. When we get into clubfoot, so all we're going to talk about cavus, valgus, varus feet. Okay. If you need a refresher, come see me or let me know during class next month, and then you can revisit that. But you absolutely need to know that to understand the pediatric clubfoot. Okay. Patients may have pain if you ask them to stand on their tippy toes. Now, as you can see, a patient that has posterior tib dysfunction may or may not have a completely flattened medial longitudinal arch, but in most cases, that arch is gone. So what do you see on X-ray? Again, if you do an AP of the foot, it's not going to tell you very much, right? If you're looking for the orientation of the longitudinal arch. However, on the lateral, you can see that the orientation of the midfoot bones, right? And that arch that is formed by the navicular and the cuneiforms, it's not there, right? It's all flattened out. Who knows what pes planus is? Flat foot, right? And so, PTTD, right, posterior tendon dysfunction, it's classic in patients with flat feet. Now, all that said, it's not the only thing that is going to cause flattening of the feet, right? But if you have significant posterior tendon dysfunction, you're more than likely going to have flat. And again, what kind of films do you, X-rays do you get for you take? Weight bearing X-rays. All right. So how do we treat these? Well, same thing, right? NSAIDs, ice if it's significantly inflamed, activity modifications, right? Always stop the offending activity. In some cases, you may have to put the patient in a short leg cast or brace to help with maintaining that longitudinal arch. You can give orthotics, right? You have orthotics that's the main function is to help maintain that arch, right? These are specialty orthotic devices. You have to go to a brace shop to get those. You can buy some from online, they're just not as good, right? And you go to a brace shop or you send the patients to the brace shop, then they can get them custom fitted for their particular feet, right? Custom application. In cases where there is inflammation of the tendon sheath, right? We try not to put them in the cast, especially if they have flat feet, because it just irritates them, right? In the absence of flat feet, take a chance, but definitely if they have flat feet and tendonitis, it tends to irritate the conditions. There are lots of tendons that we inject. And so if you have a peroneal tendonitis, right, which is pain on the lateral side of your foot, right, sometimes you inject those. If you have Steinbach's disease, right, you guys remember that from the hand, sometimes you inject those. You tend to not want to inject the posterior tib tendon, okay? I've seen some badness happen. The other structures that run very close to the tendon, and didn't turn out so well. In cases where non-operative management fails, then they come to us in ortho, either for an arthrodesis or tendon transfer. Right? And so we take other tendons, we produce this tendon, just fuse them together, and the patient has some good outcomes. So what are some red flags, and pay special attention to these, right? The patient that presents with unexplained medial ankle pain, right? We talked about in fractures and ankle sprain, we talked about the deltoid ligament. If it's compromised, then that means some other bandage going on in the foot, right, in the presence of an ankle sprain. Same thing on the medial side. So lots of things going on the lateral side of your foot. However, if you have medial side pain, then you should pay a little more attention. Sometimes you put on a short leg walking cast. All depends on what's going on with the patient. All of that is done with your referral. Questions on PTTD? Okay. At the base of the fifth metatarsal, we're going to talk sesamoiditis. There are two small bones that are wrapped up in the tendons and ligaments at the base of the fifth, called the sesamoids. Question that was asked today: how do you tell if you've got pain at the metatarsal head of the second to fifth metatarsal? You call it metatarsalgia. What do you call it if it's at the base of the fifth? Very good question, right? There's so many other things going on at the base of the fifth. It is still an irritation of the metatarsal, right? So technically, you can't call it metatarsalgia, but more specifically, it may be an inflammation of the sesamoid bones, right? Different diagnosis. Yes. First. That's okay. All right. First metatarsal. Okay, so as these sesamoid bones get irritated, then they may irritate the metatarsal head beneath them, right, causing additional pain. These sesamoids are absolutely essential and part of the windlass mechanism as well. However, and you see when we get into treatment that there are some times that you can actually remove them without any significant complications in patients. Okay? Patients that have osteoarthritis of the first NTP can also have irritation of the sesamoids, compounding the problem. So, again, exquisite pain under the first metatarsal. There may or may not be swelling. Normally you see these in people that do a lot of high impact sports activities, or people that are not conditioned and getting into sporting activities, right? So in kids, older adults, even the elderly, right? And then, just like over other conditions, you want to watch the patient walk, right? If you see that they're favoring or not favoring the affected extremity during the push-off phase, that's a way that you can tell. Because as soon as you bend the toe, you put more pressure on the sesamoid, and so it increases their symptoms. Check for range of motion always, right? And so that range of motion, if it's limited due to pain, that's one thing. If it's limited because you just cannot bend it, that's a different condition altogether, right? So if you have loss of extension at the first MTP, right? Loss of extension, that's not the same as if they have difficulty bending the toe because it's painful. You guys with me? So that loss of extension, you find that in what? Hallux rigidus, right? But if it's painful, but you can still move it, then that's a different condition. In some cases, you may have a bipartite sesamoid that mimics a sesamoid that is on X-ray. So you get the sesamoid fracture on X-ray. So in some cases, the sesamoid bone can actually fracture into two pieces. You do an X-ray, you look at, and you see two sections of the sesamoid. One way you can tell is that in a bipartite sesamoid, the margins, right, are very nice and round, whereas in a fracture, they will look a little more jagged, and you could probably fit them better together, right? Any way you can tell. You got to be careful that because they have a bipartite sesamoid and sesamoiditis doesn't mean they have a sesamoid fracture. But you have to be careful that if they do have a sesamoid fracture, then you treat them a little differently. So, to differentiate the two, look at the margins, right, of the sesamoid bone. And you can always compare it to previous films or to the contralateral side. So, how do we treat these? Non-operative management, avoid the offending activity. You can use heel pads, not heel pads. You can use orthotic pads, right? Just make sure you place them appropriately. Stiff-soled shoes that prevents bending of the first MTP. Some cases, you can put them in a little fracture brace, right? So they can take off at night and put on during the day when they're walking. And when all that fails, refer them for operative management. Some cases, you can just simply remove the sesamoids. Okay? Now, let's talk some deformities of the lesser toe. Pay attention to this chart. I'll teach this whole lecture based on this one chart. Cover 3 sections or 3 different conditions. Hammer toe, claw toe, and the mallet toe. All 3 of these occur with the lesser toes. Doesn't mean that it cannot occur with the big toe, but they're more common in the lesser toe. You only have 2 phalanges in the great toe. You have 3 in the lesser toes, which makes these more common in the lesser toes. Okay? In claw toe looks exactly as it says, like a claw. Your MTP, the metatarsal phalangeal joint, is usually fixed in flexion. So where the metatarsal meets the first phalanx, that is fixed in flexion. And then the other 2 joints the MTP is fixed in extension, right? It's pointed upwards. And then the other 2 are maybe fixed inflection or not. Right? So for claw toe, the MTP is an extension, and the other two may be inflection. In a lot of cases, you've got the PIP, right? The proximal interphalangeal joint might be fixed. In some cases, it's not. But you can tell because the toe looks like a claw. In hammer toe, the MTP may or may not be fixed in extension. Most times it's flexible, you can move it, but the PIP is usually fixed in flexion. Okay. And that just leaves us with the mallet toe, which if you look at the difference between a hammer toe and a mallet toe, the dysfunction of the mallet toe are in two places. One, there is some extension at the MTP, right? But always that DIP is fixed in flexion. If only the DIP is in flexion, that's a mallet toe. We can talk about the intrinsic muscles and how they come together and all the conditions and osteoarthritis, etc. But if you cannot recognize these, right, then it's a problem. Okay. Now, in the diabetic foot, you will see one or more variations of these three conditions. Okay. Diabetics are very prone, particularly to claw toe, right? Just because of their neuropathy and weakening of the tendons and intrinsic muscles. Okay. If they got Charcot-Marie tooth, then that even seals the fate for them. Okay, we'll talk about that in another lecture. Any questions about this? These things are very common, and we see them a lot in older, especially overweight females, right, that have other toe problems that they develop some of these. Because of the orientation of the toes, then you can expect, as we talked about earlier, the presence of corns and calluses based on which condition you have, right? In some cases they are painful, in other cases they're painless. A few minutes ago I told you that, you can have a callus usually on the bottom of the foot, and the calluses are generally painless. But there are exceptions. This is an exception, especially in the diabetic foot, right? One of the problems with diabetics is that their peripheral issues are painless, right, because of their neuropathies. So, if you see a patient that has a history of diabetes and they have pain in the foot anyway, that should alert you, right? Some additional red flags. And again, check your motor and sensory and do your range of motion. So all of the foot problems, the assessment is generally the same, right? To look at it, watch the patient walk, then you palpate it, do your range of motion, and then you initiate your treatment. Okay? Stop the offending activity, first thing, right? Apply some NSAIDs, physical therapy, and then you do, if that fails, apply orthotics, roomy toe box to spread things out. And then you send them to Ortho when non-operative management fails. Red flags, if they've got claw toe, got ulcers, especially if suddenly the painless ulcer becomes painful, have a high index of suspicion for osteomyelitis. Okay. And if you suspect that the patient has claw toe, there's a high arch, or there's a loss of the medial longitudinal arch, then by all means, refer them. Another condition that you find in the foot, and this is, we're going to stick with the great toe, is something called turf toe. You see these in young athletes, probably the condition that is responsible for the most missed days from playing, right? It's turf toe. It's called turf toe because playing football and soccer on artificial turf, then there's hyperextension of the NTP, breaks the capsule with or without a fracture, right? Becomes painful, now they can't walk or they have difficulty walking, right? That's all the turf toe is. So the degree of injury, it varies, right? So you can vary anything from a sprain to actual soft tissue rupture, or to an actual fragment of bone pulling off from either the proximal or distal end of the NTP. How do you treat these? Same as you would for any other condition involving the great toe, right? Rest, NSAIDs, and then you continue to monitor them, right? Make sure that you stop the offending activity. So if they're playing, then you have to take them off the field. Okay? We grade these and apply different treatment modalities based on our grading. So, in the case of a grade 1, in which there is just a stretch of the capsule and mild symptoms, they can continue playing with limitations, right? Grade 2s, then they might have some swelling and ecchymosis, plus or minus decreased range of motion. Okay, then you have to take them off. A grade 3, can't walk, absolutely marked swelling. You tell that there is something wrong. There's a fracture. There is loss of, or there's rupture of the capsule or the muscle, or an avulsion of the bone, and so you take them off the field. Okay, if you don't treat these, if they go on for a long time, then they will develop osteoarthritis at the end. Bad thing. Any questions about it? Good. One thing that we can do for most patients with foot maladies is put them into a shoe that limits flexion or extension, limits extension of the first NTP, right? And that hard sole shoe is the thing to do that. So instead of putting them in a cast, you don't want to immobilize the entire foot if the issue is at the toe. So you just immobilize the toes, and that's what hard sole shoe does. If you suspect there's a fracture, then you can give them non-weight bearing, put them in crutches, etc., etc. One thing I want you to note is we talked about 4 to 6 weeks, right, of most ortho conditions. So start there. That's your starting point. This is how long they're going to be out of the game. Most parents, right, if this is a young high school, football player, parents do not want to hear that. So you have to explain to them why you need to take them on the game for 6 to 8 weeks. If you got strength coaches or physical therapists on the field, then those guys are the best friends. Okay, we've covered all of these. Metatarsal, plantar warts, posterior tib tendon, toe deformities. What questions you have? None? You guys tired? Did Philomena really weigh you guys all that bad? This is crazy. Okay, We are going to end here for today. So you get an early lunch. If you have any questions, I will be around, so feel free to